fall prevention just with a vitamin D intervention program is well known as well. What is my selfish interest with vitamin D? I see a lot of those problems in shoulder patients because of the suprascapular neuropathy that comes up, and that leads to a lot of rotator cuff wasting. So that's why we combine this with our shoulder rehab programs and have improved our clinical results significantly because of this. So just giving them medicine does not improve the strength, but combining our rehab programs with vitamin D intervention makes a huge difference in our patient population. We'll skip some of these slides, but what is important is even the Western population, they found that the average intake was only 200 units. This is the meat eating, milk drinking population. They get 200 units of vitamin D in their daily lifestyle. So let me finish off with this slide, where the whole debate was about why do we need to measure vitamin D, and we do extensive measuring, which we'll see on the next graph that follows up. It's very important because I don't know whether you require 6 sachets of calciferol, 60,000 units, or you require 6 injections of iratropol, 6 lakh units. Once you start taking 6 sachets and come to me, and then I cannot test your vitamin D levels for a long period, and so we will never know whether you've been adequately treated. Best thing to do is to do an annual intervention like we do for all our patients, and we go by the international recommendation where the trough levels are checked, the lowest levels in the year. So we give them a 2-month drug holiday and then check their vitamin D levels so that we can decide what are their annual requirements for these patients. Just to show you, this is our chart of all the patients that were done. Thanks to Manisha from Golwilkar provided all this data to us. These were 840 patients tested in 2013. If you look at all our patients, 74% of those patients were well below 20, and some were dire in their levels where 4 and 5 levels is not uncommon. There were very few minuscule number of patients who were in the healthy range. We did shave off 6 patients because they were 120, 130, because they were probably inappropriately tested because they had just taken dosages. So this is the reality, this is the fact. So we can't have this ostrich's attitude where we think that vitamin D testing is not necessary. We do an extensive testing across the 3 OPDs that we do, and this is the fact because our eyes have opened up because we started testing it. D toxicity is very unusual. We have had, I'll give you 2 examples. We have had one patient where instead of taking the iratropol once a month for 6 months, ended up taking once a day iratropol for 6 days, and then woke up, and then he came back rushing to us. And then he said that, I'm sorry, because patients are daft, we write some very good prescriptions, but it is inconceivable that I can change a patient from a vitamin D deficient state to a toxic state. A healthy patient, if you give him too much of vitamin D, you could contentionally push him into the toxic range. It's very unusual. Over 2007 onwards, we're doing a lot of vitamin D studies, and we have not had a patient in a toxic range. There have been some discussions with physicians where they came back and said that patients are behaving differently. I think you're in the toxic zone, shall we put them on steroids? We've not had to do that for a single patient. We've had at least 2 or 3 patients taking excessive dosages. The tolerance levels are very high, and especially when you give them orally, the gut ensures that it will take only as much as it wants. Do not put them into injections because that can potentially convert them into terribly high levels. But now the international tolerance levels are well above 100. The suggestion by Michael Hollick was that if levels are 200 and above, then press the panic button. Till then, you don't need to. So in conclusion, let me say that our upper limits of vitamin D that we are projecting today are far too low, and they are preventing our national programs or policy formulations because we are dealing with very low levels that were decided ages back. It is not relevant to today's day, and because of which we are affecting, we cannot decide the PTH levels, we cannot reduce the number of fractures and the disease problems. The final appeal is that, one, we must recognize that this is a significant public health problem. The costs of the test are the only major criteria that are preventing us from doing the test on a regular basis on all our patients. So if we can, because the volume of tests have gone up, we can all collectively come back to that and make it to a sensible level. But some of the other labs are just ridiculously charging the patients willy-nilly, and that is preventing patients from getting them done on an annual basis. A lot of variability between the different labs as well, but that I think Manisha will touch that subject and rule out our apprehensions. But we seriously as a country need some significant dietary guidelines. I'm sure Yagnik sir will help us on this. because unless we formulate, our patient population is going down significantly. We are seeing a lot of disease population at much younger ages, and it doesn't affect me as an orthopedic surgeon as much. I'm sure you're seeing the picture because the writing is clearly on the wall. Thank you very much.